please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
How's your week been so far?
Amazing. I have a patient who came in from Hawaii.
Mm-hmm.
He has a very rare condition called Sclerosing Mesenteritis. So he's had 4 years of Latin pays off. It's the mesentery that gets sclerosed.
Yes, had to engineer that.
He had Crohn's since he's 15, and he's now 71. And this sclerosing thing started in about 2015, and then it got worse, and he developed atrial fib, and he developed dysphonia, all in 2020, 21, after he got vaccinated and then got COVID 4 times.
I'm going to stop you before you start because we do have lay people that listen to the podcast. So those of us with our medical terminology background have been able to translate what you just said.
Okay.
So I'll have you just kind of back up just a little bit for the lay people, if you wouldn't mind.
Lay people is, yes, good point.
Thank you.
The mesentery, I thought it was just the peritoneum.
It's not?
Apparently not, according to Netter.
Okay.
The peritoneum is like this big sac that encloses all of your guts.
Yeah.
Small intestine, large intestine, stomach, pancreas, liver is all inside of this sac that's made of fascia. The mesentery is part of that peritoneum, but it has a few little attachments that are in the back and to the intestines that have separate name tags.
Okay.
I thought they were the same thing, but there's 2 different names for them. And then sclerosing is another word for scarring. So I guess they get more points if they use bigger words. You can't just say scarring of the mesentery, right? That's too boring.
Right.
So you have to call it sclerosing, and then mesenteritis means that the mesentery scarred because it was inflamed.
Right.
Okay.
Anytime you hear the suffix itis, you know it's inflammation of. Lay
Yes.
people. There's your pro tip for today.
There you go. Just so you can help translate for those of you that haven't taken 4 years of Latin in high school. The only reason I took 4 years of Latin in high school was so that I would be able to understand medical terminology when I got to college.
Yes.
Anatomy stuff.
Latin and Greek will get you through those courses.
I think Greek would break my brain because of the funky alphabet. At least Roman is in Roman letters. They're just arranged kind of funny.
Right.
Anyway, so the first day, you have this belly that is just rock hard, enlarged, but rock hard. And it's okay. So what's there? So you look at Netter, and there's skin, but the skin's not the problem. There's the mesentery, the peritoneum. That's a problem because it's scarred. So you poke his belly and it doesn't go anywhere. Then you've got the omentum under that, and that is made of fat and lymphatics and a lot of blood vessels. And he's had 3 surgeries. 2 surgeries took his small intestine and took 8 centimeters out of it. And then the second time they took 6 centimeters. And the third time it was obstructed. They thought they were going to have to take stuff out of it, but they just had to unkink it. And so he's had his belly opened up 3 times. And while they were in there the first time, they took out the cecum. So there's the ascending colon, And the cecum is where the small intestine attaches to the large intestine. And there's kind of a little ball down there, round place, that they call the cecum. So they took the cecum out and they had these scars that you could feel that were really tender. And the fun part about the first day was it was kind of simple, which sounds weird, but he has atrial fibrillation. And for those of us that have taken FSM, anybody with atrial fibrillation, and he has dysphonia, which means it's really hard for him to talk. His vocal cords are really tight, and his voice is really like this. And so that means the vagus nerve is not working. So we ran concussion and vagus from his neck to his belly. We ran just vagal tone multiple times. And every time it got to the vagus, he started snoring. And then we had another 3 machines from his back to his abdomen. And we did, you think about the tissues, sclerosis in the adipose, right? And then inflammation in the adipose, because the inflammation is in the mesentery, and the scarring in the mesentery didn't come from space. It came from the omentum, and that came from Crohn's disease, right? So it's all inflammation, but it starts in the small bowel and then it goes to the omentum and then it goes to the peritoneum, just because it's so close, and why not? Worked on his scar tissue, made a bunch of progress, and we tried to get it on film on Monday, and the camera didn't have any sound and it wouldn't work right, and Kevin got really annoyed. So Tuesday morning at 8:30, I called David Eakes, who does the videography for our core and advanced in Phoenix, and said, "Hey, are you busy today? No? You want to come down from Seattle to Vancouver and videotape this thing for me? The patient's coming at 1 o'clock." He said, "I'll pack up and I'll be there."
Wow.
So we caught, David says it's only an hour and a half. I think it was closer to 2+ hours. I finally have on video how to use your hands on somebody with abdominal adhesions. Flat fingers, feel for it, press, wait until it softens a millimeter or 2. And then once it softens, you just push it 1.5 centimeters or 2 until it stops. And then you wait again. We got all of that on video. And he said something important the second day, which is, it really hurts when I walk. That's what makes my gut the worst, this mesentery. That's what makes it worse. If you listen very carefully, the patient will tell you what's wrong with them. So what's wrong with them? That means the mesentery is adhered to his psoas and to the spine.
Right.
So we did, once I got his belly soft enough that I could get into his psoas, I ran scarring in the ureter, scarring in the kidneys, sclerosis in the adipose. Mind you, this whole time, when I said I had 3 machines on him, there's one machine whose only job was to run scarring in the vagus.
Mm-hmm.
From it, see, makes perfect sense to you.
Yes.
Because the vagus is a pain nerve in the abdomen. From back to front, scarring in the vagus, and that was actually the first thing we ran, so that there would be enough softening that we could get into his intestines. And then we ran COVID, all the virus frequencies in the vagus, all the virus frequencies in the small intestine, all the virus frequencies in the capillaries and the arteries. So all of this stuff got worse after COVID. The mesenteritis started 5 years before that. So that wasn't the initiating factor, but he got the dysphonia and the atrial fibrillation after COVID.
Okay.
So this goes back to someplace in the webinar stack. There's one that says take it apart. This goes back to taking it apart. Anyways, we got all that on film. And so now finally I have a tutorial, I guess, on how to treat the viscera. And it was just really fun getting his kidneys to move, his psoas to be non-tender, and then getting the mesentery or the fascia to let go of his spine. And then, yeah. And then after that, since David was there, we videotaped the vestibular slides. I updated the vestibular section of the core, and I'd been meaning to turn that into a webinar or a practicum because people are pretty brain dead by Sunday when I get around to it. And it's the most important thing we do in the core. And so we really need it just by itself. And so we got that filmed, and Kevin volunteered to be my demo for the physical exam.
Great.
He put the tuning fork in the middle of his forehead and it's like, where do you hear that? And he said, both ears. And then I tested air conduction on both sides. And on the left-hand side, he just went. So it was aversive. And I said, let's go.
Air conduction.
So you take this tuning fork and the little heads on the tuning fork go vibrate like that, and they make this buzzy sound. Air conduction, so bone conduction is when you put the tuning fork on a bone and the bones conduct the vibration to the ears. When you take the tuning fork and you put it next to the ears so that the little vibrating parts make sound that you hear by air, that's air conduction. And air conduction on his left was bothersome. Let's go back to your forehead. And he said, I expected to hear something like, but mostly it's just buzzes, right? Where does it buzz? Only on the left. And it's aversive on the left. And then had him follow my finger. So Kevin has a vestibular injury. Pardon me, Kevin, for ratting you out and disclosing publicly, but he had a fall where he fell on his bike, wrecked his left shoulder and his left ear. And he's had trouble reading. And so he gets to have prism glasses. And it was just like the perfect demo. And we got it all on film.
Great. So we have to back way up.
Back up the truck.
Back it up. That's what we do. You go forth on the train and I try to reel you back in again before you go somewhere.
God knows somebody has to, right?
I want to go back to the viscera for a second because I think, number one, great that you got it on video because we do talk about the speed and how much the palpation changes. And a lot of us in physical medicine have to really switch gears from our diagnostic touch to our treatment touch. And the viscera, there is no room for error because if you go too deep, too fast, it's exquisitely painful. Everything tightens up. And I feel like you only have one shot. So you have to go slow and you have to listen and see with your hands. However, you talked a lot about different tissue types. And there once was a rumor floating around town that adhesions in the adipose had a different sensation than adhesions in connective tissue or in muscle belly. As far as adipose adhesions for the patient will feel sharp, they'll feel hot, they just feel different than a regular trigger point.
Oh, yeah, it's a completely different, and adhesions or scarring in the vagus is that one's sharp. What was interesting is as we got further down and into different parts of the abdomen, when I got to the anastomosis in the small intestine, you come up from the side and you run into this pipe that goes this way, and it's clearly the small intestine. You can feel the anastomosis where the two ends of the small intestine and the ascending colon, the end of the small intestine and the middle of the ascending colon were stitched together. You could feel that bump. And so we did scarring in the small intestine, scarring in the ascending colon. The adipose is hard. It's firmer, crunchier, but it softens. It was really nice. Sharp was scarring in the vagus. And then yesterday, as I got down lateral to and just below the umbilicus on the left-hand side, I got to a spot where he went, "Oh, that really hurts." And I was barely touching it. And that takes us back to sharp pain with gentle pressure is what? Scarring in the nerve.
Mm-hmm.
Well, it was superficial. I mean, it was like in the first first centimeter of depression. And you could follow it down. And this is one of those weird things where you have mileage. I had a patient one time, but you never forget the ones that you have to work for, right? This guy fell backwards over a carpet roll, and he basically had CRPS in the cutaneous branch of the iliohypogastric nerve. And the only reason I know that is that he had a numb and hypersensitive spot on his abdomen, on the skin, that makes it a cutaneous nerve. But it was a cutaneous nerve that came off a deep nerve called the iliohypogastric nerve. This was a cutaneous branch that came off that nerve that feeds this part of the abdomen on both sides.
Hang on, quick. Louise just came in. What is CRPS? CRPS is complex regional pain.
Pain syndrome. Yeah, he had a torn nerve. When it's numb and hypersensitive at the same time, then you know that the nerve is torn. So when he fell backwards, he had an appendix scar, adhesions in the nerve, where the nerve was like stitched down. And then he fell backwards over a roll of carpet that was 3 feet in diameter. So he did this extension thing and basically tore this nerve. And there's no earthly reason why anybody would know that there is a cutaneous branch of the iliohypogastric nerve. Who knows that, right? And the only reason I know it is that it took me 30 minutes to look it up and find out where the heck it was.
Yeah.
On this patient, when I got to that spot on his abdomen, I know what that is. Now, if I hadn't had that prior experience, I would have gone to Netter and fished around until I found it.
Right.
So then I switched to scarring in the nerve.
Yeah.
And that burny, uncomfortable, painful sensation went away. That was pretty fun. The sclerosis, the scarring in the lymphatics. So you think of the omentum, we have one case report. It deserves an hour and we didn't have time. So 30 minutes on the omentum, and the omentum contains an enormous quantity of lymphatic tissue, and 85% of the immune system is clustered around the digestive tract, and that includes the omentum and the digestive tract itself.
Yeah.
So then all the lymphatic channels go down through the groin. When I first did the physical exam on him, I felt the pulses in his feet, and there was a nice little thump, thump, thump. So he had pedal pulses. Pedal just means foot, like pedal pulses. But his femoral pulse was like, if you put the femoral nerve is the size of your little finger or your index finger. It's huge. Femoral artery, femoral artery. He didn't have a femoral pulse. Couldn't find it. Okay. Now his pulse was slow. It was 56. I did scar tissue in the lymphatics, scar tissue in the arteries, scar tissue in the veins. And at the end of the hour on Monday, you could feel this slow femoral pulse. And at the end of the hour and a half on Tuesday, you could find the femoral pulse. I mean, it was just on its own, it was so much fun. But to be able to explain to students how you can have your hand completely relaxed and exert enough force that you can take a fairly round abdomen that's scarred and get down to the psoas and the ureter and the blood supply and the adipose and the mesentery, which is basically fascia. We don't have a separate frequency for mesentery. So that was the most fun I had yesterday.
And I have to back you up. Oh, when you're first describing this patient with the visceral scarring, you had mentioned a couple key phrases. Now, Crohn's, correct me if I'm wrong, is autoimmune.
Yes. Yeah. Yep.
So just hearing that in itself, my brain shifts to have to treat the vagus.
Oh, yeah. I mean, we treated the vagus
The whole
3
time.
times, and it was really the whole time. So I have one on vagal tone and one on concussion in vagus. And every time I ran them, he fell asleep and started doing little angel puffs, snoring. And then when he woke up and I got to talk to him about what was going on in his belly, I went and turned vagal tone and concussion and vagus back on, and he passed out again. So I could make him fall asleep anytime I wanted just by running concussion and vagus and vagal tone. That was pretty fun.
How much of what you did do you expect to hold because of the underlying Crohn's?
The thing is,
people, maybe we need to back up and describe what Crohn's is.
Crohn's is when your immune system decides that your small intestine or your esophagus or your part, it can affect any part of the digestive system. Most commonly, it's the small intestine, and on him, it was the small intestine. Your immune system decides it belongs to somebody else. So the immune system attacks your own digestive tissue lining, and it's inflammatory. They never had him on immune suppressants. They managed, it was the good old days. I mean, he's 71, so they used basically steroids. So he's been on steroids pretty much since he was 15, on and off. So they'd wean him off and then he'd have a flare up and they'd put him back on. And so then the Crohn's was declared to be in remission. And then this mesenteric sclerosis started 2015.
10 years ago.
Yeah. And then 5 years after that, he got vaccinated and got COVID 4 times after the vaccine. And that's when he got that's when the vagus really went. So in order to have an autoimmune disease, your vagus nerve has to be half asleep because the vagus has its job to suppress the immune system, keep it under control. Yeah, no, you really don't need to jump on the small bowel. It doesn't belong to you. It belongs to this body, and you need to just go lay in a corner calm down. It's just fine. And so he had vagus nerve problems to begin with.
Right.
And I said, so infection, stress, or trauma when you were 14 or 15 and this started? I said, I don't know. I mean, some stress. What teenager doesn't have stress? And I went, we'll just put a pin in that. And then later on, somebody convinced him that taking worm eggs, parasite eggs, was a way to get that's a good face, was a way to get the immune system to get unconfused. And so that was a whole nother conversation. I let that one go because it's a done deal, right? And I find it interesting that they took out the worst of the scarring was in the cecum, the appendix, where the small intestine joins it. And parasites tend to hang out, live, reproduce, build little forts and, cabins in the appendix, the cecum, and then go right on through to the small intestine. I said, when you were a teenager, where did you live? And he lived, I think, in Minnesota or someplace upper Midwest. And I said, were you an outdoor sort of kid? Did you drink out of the creek? Did you, eat, stuff that had dirt on it? And he said, I can remember when I was a kid eating dirt. And then, sure, I drank creek water. Did you ever get diarrhea? Sure. Okay. Did anybody ever treat you for parasites? No, I just had diarrhea from drinking creek water. What's that got to do with parasites? So we had that conversation. So he's going to have a list of things to do, one of which is have somebody put you on these 5 anti-parasite medications, one after another for 6 weeks. And that'll take care. I still suspect that the parasites are what started the Crohn's to begin with.
Right.
And then because they're still hanging around, that's what led to the ongoing inflammation.
Right.
and the scarring. Somebody asked, you started with AFib. How do we treat this with FSM? The atrial fibrillation is the bottom part of the heart is the ventricles, and they're thick muscles. Like it's the business end of the heart. It does the contraction that's hard enough to squish all that blood out all the way through the atria into your body, and then out through the atria into your lungs to pick up oxygen before it comes back in the other way and then goes out with oxygen. The vagus innervates, the left vagus innervates the ventricles, the muscle part, and the right vagus innervates the atria, and the atria are not muscular like the ventricles. They're thinner, but they have electrical conductivity, and they're sort of linked with the ventricles because they have to fire in a certain order in order to get the blood where it needs to go. If the vagus isn't working right, the ventricles, instead of beating the atria, instead of beating like the rest of your heart, thump, 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 63 times a minute, the little electrical plug in the atria can start beating really fast. And it just takes off. So it can beat up to 140, 150 times a minute. And when it does that, it just gets sort of fluttery and doesn't do a job of moving the blood where it needs to go. In order to slow it down, the role of the vagus in the heart is to slow conductivity in the ventricles and the atria. George had atrial fib, and we could turn it off in about 10 or 15 minutes with just running increased secretions in the vagus around the neck where it comes out behind the ears, and then down just below his chest or right over his chest. And because he didn't have a pacemaker, and neither does this guy. So I said, oh, I'm in and out of atrial fib. Okay. So atrial fib, you just treat the vagus. And there was one other thing. It was really cool. He said, oh, and my neck is really tight. And he didn't point to his neck. He pointed to here, right behind the ears.
SCM scalenes.
It's actually where the vagus comes out, right behind the ears, the jugular foramen. There's a little hole where your jugular veins go in and out of the brain, but it's where the vagus comes out, the jugular foramen. And then the vagus forms this spider web that goes up under your jaw, into your palate, into your tongue, makes saliva, makes mucus, makes your palate go up when you say, makes your epiglottis close when it's supposed to so you don't choke on your own spit, innervates the esophagus and bronchi and all that. So there's this big spider web. And so one of the things I did the first day and the second day was scarring in the vagus in his neck. First day, because the second day he came in and he said, the weirdest thing happened last night. When I got out of the clinic and headed in the car, I turned my head and my neck popped. And then about 2 hours later, I turned my head the other way and my neck popped. And about 3 hours after that, it popped 3 times. It's never done that. Yeah.
I mean, the common theme I'm hearing from many different directions is the vagus nerve. I'm hearing it in the neck. I'm hearing it with adhesions in the gut. I'm hearing it as a driver or a causative factor to Crohn's. So, I mean, there's three different scenarios where it's just screaming at you to notice me, treat me.
And dysphonia and atrial fib and Crohn's and painful belly.
Right.
It's just, and stiff neck.
Right.
It,
How much of this will last and how much of this will need a custom care on a regular basis?
What's interesting is they already have a custom care. And the person that programmed it for them in Hawaii just put on the wrong stuff. They've been treating, it's like, why are they treating, like 7 out of the 10 things that were on it were completely useless for what he had. I thought that was interesting. But when you take apart scar tissue, the nice thing is it stays apart.
Mm-hmm.
It does, when you break up the bonds that hold the scar tissue together, and then when they go to try and reform, they're not in the same place. It should be more or less permanent. One can hope. That's kind of the plan anyway.
I'm thinking again with the vagus, how much constant support the vagus nerve is going to need.
Oh, we'll have concussion in vagus and vagal tone programmed onto his unit. And I probably will program scarring in the small bowel, scarring in the sclerosis in the adipose, scarring in the lymphatics, scarring in the capillaries, right? Because the omentum is full of capillaries and lymphatics.
Yeah.
And just for maintenance at home. And he'll be taking Huperzine A. It's a supplement that is it's not prescription strength, obviously, but it's a mild acetylcholine esterase inhibitor. Acetylcholine is what the vagus uses as a neurotransmitter. And there's an enzyme, acetylcholine esterase, whose job it is to take acetylcholine apart. So you give the patient something that will slow down that enzyme and leave acetylcholine in the synapse just a little bit longer. So
that's a supplement. It's non-prescription. You can get that wherever you get your supplements.
Huperzine A, there is a prescription version of it that's much stronger, but I don't know, in 19,
H-U-P. Oh,
H-U-P-E, E-R-Z-I-N-E
and letter A.
dash A.
Yeah.
And I can remember my mother taking that for cognitive function in 1990.
Wow.
So Huperzine A used to be prescription. Then they came up with the stronger version of it. So they made Huperzine A over the counter, and the prescription strength or prescription item is still available. It's fascinating.
Very neat. All
Yeah,
the things that we learn in this podcast.
it's and the thing is you'll have this, the nice thing about this video is in this is a very rare condition. So the odds of anybody that's listening seeing sclerosing mesenteritis is like zero. You're never going to see it. But you're going to see endometriosis patients. You're going to see Crohn's patients. You're going to see IBS patients. You're going to see patients that have had, ruptured appendix, peritonitis, anything that inflames the whole belly. You're going to have a bunch of scar tissue and low back pain. And so the important part about getting it on video was how to place your hand. Relax your wrist, relax your fingers, and the only thing you contract are your finger flexors or not even your dips. It was just the way his belly was configured. I had to go this way with my hand, and being able to demonstrate that and talk about what makes you stop. So you're pressing and you get to something that's hard. As soon as you touch it, you stop and you wait. Figure out what it is, go to scarring and whatever that is. And there's a question here about any concern of undoing the anastomosis with 13. No, the anastomosis you could feel. The person that did it did a really good job. An anastomosis, you take this tube and you overlap this tube and then you stitch them together. So you have a double thickness ridge that you could feel. And I thinned out the scar tissue, but the small intestine was not, it just wasn't mobile in that spot. And it should be movable.
Right.
Thinning out the anastomosis was one thing, but getting under the small bowel and running scarring in the adipose, scarring in the capillaries, scarring in the ascending colon, scarring in the small bowel. It's just, I opened Netter up to show them. I pretended it was to show them. It was really so that I could get another look at where everything was.
Right.
And so that we had a landscape, a map of where we were going to go and what needed to be done.
I think we hear that that's a common theme and question with 13 is, will it undo scarring that was, holding something post-surgically intact or so on and so forth? I haven't seen that happen. Have you?
No, I really haven't. I haven't had any difficulty with that at all, ever.
Right. We use it, we say also as a precaution in the acute stage, in those initial few weeks of healing, to not run 13 when the body is forming a scar. We don't want to interrupt that. So we let the body do its thing. And then after, 5-6 weeks, you can start using it. It's very helpful with a little bit of cross fiber friction. You can help organize as that scar is forming, but we want to stay away from that in that acute initial stage of healing.
As a rule of thumb, it's 6 to 8 weeks after the original injury. You just wait until the scar tissue is good and solid. And if anything, scarring tends to be a little exuberant. So there's always extra. And it's almost always disorganized is the problem. It takes almost a year for the immune system and motion to get scar tissue organized so that it's running in the right direction, and all of the random pieces of fibrosis that go the wrong direction, those have been undone. Well, by the time you get them at 15 years later, if the unnecessary scar tissue was going to come apart, it would have come apart, and it hasn't. So I didn't worry about it too much. Kate is asking, what's the dose you recommend with Huperzine A? I have taken, there's one company makes 100 milligram. There's another company makes 200 milligram. I bought one of each. I can't tell the difference. So I'm using up the bottle of 200 milligram before I go back and use up the bottle of hundreds. So 200 milligrams doesn't create any problem with, if you have a patient that has spasticity or any problem with increased tone or tremor, you don't want to use Huperzine A because acetylcholine also contributes to muscle contraction, right? So it's multitasking. And so it makes it a little challenging. You have to be careful with it, more careful with the prescription version, but Huperzine A is mild enough. It doesn't usually get in the way. So that's pretty fun.
Going back to Omentum and Viscera.
Oh,
There's so
goody.
much to talk about with all the goodies that you went through.
We've never talked about this before on the podcast.
I know, I was thinking about that, and I'm not sure how we've gotten to 100 and so many episodes without taking a really deep dive into Viscera and Omentum, and
It never walked into the office before. And it was so unique that I called David Eakes, and he drove down from Seattle with 2 cameras, his soundboard, his confidence monitor, and we just took over this 20 by 30 treatment room that's meant for just that.
right.
So excited.
Yeah, that, as you should be. So going back to Omentum and adipose, which are crucial for a thorough visceral treatment, how much do you run toxicity in the adipose and the Omentum, vitality? Those are all those other factors that, thanks to some of our doctors that we have met through the FSM community, learning that the Omentum holds toxicity.
You know what? I ran inflammation in the Omentum.
Yeah.
I didn't run toxicity yet. So I'll try that. I see him Thursday and Friday. So I'll see if toxicity does anything. He doesn't have brain fog. He's otherwise very healthy. I mean, somebody with this rare, serious condition says, I am perfectly healthy except for this thing. And
Right.
it's okay then. So he doesn't strike me. So that's why it didn't occur to me to run toxicity. I
Right.
had one machine that ran yesterday. It ran an hour on 40 and 97 just because I was working on his left side. And I had 2 machines doing their thing on his right side. So I set one at just inflammation in the adipose, and I think the other one I set on scarring in the vagus, so I wouldn't run into it when I was on the left side of his body. The left side of his body, I was just working on the descending colon and the small bowel again, and the omentum on that left side. And the thing about the omentum is it's supposed to be slidey and squishy.
Yeah.
It's supposed to be the slidey thing that gives your small intestine circulation, physical protection. You know, if your dog jumps and puts his paws on your belly, you don't want the dog's paws to run right into your small intestine. You want some cushion. So that's what the adipose is for. And it is rich in lymphatics, and so immune activation, lymphatic channels, lymph nodes, so 13 and 63,
Yeah.
and capillaries.
Right.
And then when you look at Netter, I was surprised at how many arteries there are on the back side of the omentum. Feed it.
Makes sense.
Yeah, who knew?
Similar question that I was going to say, we also mentioned about that patient having parasites. They're asking if there are FSM frequencies for parasites that you would run and if there's drug therapy for that.
There are, let's see if I can remember them, 22, 33, 43, 61, and there's another one. There's 5 different frequencies for parasites. Oh, you're checking the buddy.
Yeah, because those never stay in my brain for some reason.
22, 33, something with a 7 in it. 61, which doesn't do much.
Yeah.
2,
61, 43.
2.
Yeah, 43, 61, 22, 33.
33, got that one.
The only ones I see.
Okay, maybe that's it.
Unless
Anyway, so I ran those in his gallbladder and the ascending colon. Had some discomfort in places where he shouldn't have had discomfort, it didn't seem. So I ran those just in case, and that helped it be more comfortable. So the medications that you take for parasites are, what's his name? Dietrich Klinghardt has a sequence that my naturopath put me on. Simon Yu had prescribed 6 anti-parasite medications to be taken at huge doses all at one time, which would have been a bit of a challenge for my liver, and my bank book was about $20,000 for 4 weeks of therapy.
wow.
Yeah, so we didn't do that. So my naturopath said, Dietrich Klinghardt has a series, and you take mebendazole, which I think in Mexican grocery stores is over the counter. You just buy it the way, just right off the little shelf. So mebendazole, praziquantel, ivermectin, something else that somebody could help, and then Alinea. So there's 5 of them. So you take 3 days of mebendazole. Oh, metronidazole, which is Flagyl. That one's everybody knows about. Then praziquantel, and ivermectin has to be compounded in, they give it to horses as a gooey liquid, but the dose is wrong. So ivermectin you have compounded into capsules that are the right strength for humans. And when I took these, the only one I noticed anything strange about was ivermectin. You know, how you get off the toilet and you look in the toilet. And after ivermectin, my first dose, I just did this double take because there was this white fuzzy ball in there. That is not normal. And then Alinea is the new one that is very broad spectrum. And you're supposed to do each one. So 3 days, 5 days, 3 days, 5 days of something else, and then 10 days of Alinea. Then you wait 6 weeks and you're supposed to do it all over again. I didn't do it the second time, but I seems to have got, fenbendazole is available. Leaf, you're just a fountain of information. Via Amazon, it comes out of Latvia. That's interesting. Oh, Thad says huperzine A goes in micrograms rather than milligrams. Whatever. It's 100. There's 100 and a 200. So got that. Anyway, so the anti-parasite medications. Now, some of the naturopaths like to use oil of oregano and wormwood, herbs and whatever. When it comes to parasites, I'm not even nice. I believe in chemical warfare. And because the little critters just create an enormous amount of trouble, activate the immune system, just sort of burrow in and make a house, build little towns in your appendix and your gallbladder. It's gross. Yeah, that's a good face. It's like gross.
Yeah.
Yeah.
Okay, we have a couple more questions just to make sure we get them. Removing scars when an ablation is performed for AFib/flutter. It works due to the scarring around the PVs and Cox lines. Will it affect the scars? She's been implementing scar frequencies, believing it to eliminate would be perceived as
Extraneous.
the whole thing just went away for me.
Yeah, I can see. So I've been implementing the scar frequencies, believing it to eliminate what would be perceived as extraneous scarring in the atria. And he had atrial fib that was long-term and just really chronic. And there are patients who have multiple nodes, sinoatrial nodes. It's the electrical part that signals the atria to contract. For some reason, some people just develop multiple ones of them. So they go in and do an ablation. There should be one or two of these nodes. There are people that have 20, and they go in and they just keep ablating them. And sometimes there's more scar tissue than there should be. So then I would wonder, would you do scarring in the vagus or would you do scarring in the heart? Because I don't think we have a separate frequency for the atria. I'm not sure. But you'd wait at least 8 to 10 weeks. With atrial fib, you really want the ablation to do its thing. I get respectful. I mean, the question you have to ask yourself with FSM is, what if it works? If you take the scar tissue out of the atria, what is the potential hazard? There's that.
Yeah.
What if it works? The same thing with the lady that asked about undoing the anastomosis at the small bowel. What if it works? I could palpate as this ridge of scar tissue got thinner, and that ridge of scar tissue was always where he got his obstructions. So getting it thinner and getting the small bowel more mobile was what I was feeling for. There was never a point where if you bust through an anastomosis, you will know immediately, and you'll know to get to the patient to the emergency room, because the small bowel will start to leak or bleed, usually bleed first if you're lucky, and then you just run stop bleeding and turn that off. Can we FSM, I know we're almost done. Can we use FSM with a Dexcom G6 insulin pump? My feeling about pumps is particularly vigilant with insulin pumps. Now, baclofen pumps, there's no off switch. Morphine pumps, there's an off switch, so you can turn them off. Spinal cord stim units, which are implanted TENS units, you can turn those off. Insulin pumps have an off switch, and they always have a reservoir that can be refilled. As far as I know, the reservoir, I'm not familiar with that particular pump, but you can usually, if the reservoir is external, there'll be a needle into it and just undo the needle from the pump. Of all the different kinds of pumps, the insulin pump is the only one that can kill you. If it goes haywire and it delivers too much insulin, you're dead. I mean, that's it. You can, unless you have orange juice and other things to get their blood sugar back up really quick, and you recognize the fact that they get all sweaty and pale and not looking good. So I just turn the insulin pump off. They almost always have off switches. or unplug it from the reservoir.
There you go.
Wow. I know.
We need to revisit the viscera next week because my list is growing. It's a thing. I have so many more stories to tell and have so many more questions to ask. So part B of the viscera will be next week.
Okay, and I'll let you do more of the talking. I just got all excited about what we did yesterday.
No, yeah, this was needed. No one needs to hear me talk when there's that to hear from.
And the exciting thing is that we'll have it on tape and it will be on the resources page as we'll probably call it the Visceral tutorial. It's how to work on somebody's belly. It's pretty cool. It's 4 o'clock already.
It is. Alarms are going off.
Okay, fine. That's pretty cool.
Yeah, it's the fastest hour of the week.
It is. It's good to see you.
You too. And thanks everybody for coming as always.
Yes.
And we'll be here same time, same place next week.
See you next week.
See you next week, everybody.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.